So the principle of my talk is to look at the definitions. The remit was the power output and some of the audiological indications and some of the surgical issues. So I'm going to concentrate purely on those four items. But really, to put into perspective, we have to try and define what they have. And I've made up my homemade graphics, and I apologise for this. And if I this is your Baha, so your active process that is on the outside, but the percutaneous going into the yellow bone. So that's your past percutaneous. Transcutaneous is obviously nothing that reaches the skin. This will be the Baha and Sophono systems. The passively active vibrator is external to it. Active transcutaneous, where the processor is held by a reciprocal magnet through the skin, and the vibrating package is connected to the bone. And the classical example of this is the Medel Bonebridge. And then the last couple of devices where the active or total implantable device without any perhaps external systems are connecting directly to the acicular chain or similar devices. Okay, don't forget me. The principle is you have to work very alongside your audiologist. We're just the plumbers to put these in. So here are some of the systems that we have access to. The percutaneous, the Baha, the Cochlear or Oticon systems, Sophono, which has been bought out by Medtronic, and the Baha and Bonebridge I've mentioned, and the ones that I've played with is Esteem and the ones I've seen only in laboratories is the Codacs, but obviously we have used the middle ear implant on quite a few occasions. Put in the context of talking about the Sophono, I'm showing my age, but many years ago there was an analog system that was based on an implantable magnet and the external vibrator, but because of the power rate ratios of these things, it became like a sanding machine, and within a few weeks of fitting them, they were zapping through the skin and causing a lot of problems. But with the developments mainly by Professor Siegert, the weight of these systems, because of the digitalization, it's very, very simple. So what I'd like to talk about is concentrate on the Sophono. It's a very simple process to do, and I'll go through some of the surgical stages, but you can easily do it under local anesthetic. You only need a couple of millimeters of bone thickness, so it is very useful in young children. And the principle that perhaps I would go into here, we'll talk about audiological things. The maximum power output is about 45 decibels. And what you've got to realize that with these sort of implants, all these implants, whereas a cochlear implant, you're doing the surgery for central neural hearing loss, you're wanting to maintain the bone production, the central neural component. So you mustn't implant these patients at the maximum level of what the threshold is, because with age, your hearing will deteriorate. And obviously financially you want to get a few years of benefit. So these are for patients with good hearing, i.e. the younger the patient are. And Ad Snick in Nijmegen produced a nice little profile of looking at age-associated hearing loss with the maximum power output, and said, well, you should not be implanting in the average person this device, because by the time, say, they're 23, you have no more reserve, and if you put too much power in, you'll get distortion. My slide's slightly out of sync, but the indications for Sophono is 5 years or older, thresholds better than 35 decibels, which gives you a little bit of leeway for doing that. So if you're dealing with a child, say with my crucial or something like that, which is where I use them, you've got plenty of reserve. Single-sided deafness, I think we can talk about, because you have to have power. And again, once your good ear is letting you down, the realms of single-sided deafness does fade off. So this is a reasonably normal ear. You can have my crusher's ears, simple planning of incision, which if you're doing reconstructions, you make incision quite a reasonable distance away from the pinner, so you've got good skin flap. You mark it, then I use simple gentian violet, and that goes through to the bone, and you get little markings on the bone, which helps you position your beds. And you make little wells, only need to be 2 millimeters in depth. You do one first, and then with the template you make the other one, and then with simple dental screws it's held in position. And the profile, there's hardly any profile, it's only the thickness of the titanium which is containing the magnets which is set into the bone. So these are powerful earth magnets, and that's the patient with it on. So that's a transcutaneous system. They're now onto their third generation of processor, and the MPO is added another 7 decibels of power. So again, we're just seeing in a space of 3 or 4 years a huge lift in the power output of these things. The next one, I'm going sort of in order, not only in complexity of surgery, but in power output of these devices. So again, the Bonebridge, which is an active transcutaneous by definition, keeping your bone conductions less than 45 dB, and quite a good range of amplification, quite useful as compared with some bone conduction devices of up to 4 kilohertz do have limitations. You need stable ears, no retrocochlear lesions, and the principle is you judge where you put it dependent on the disease state. You need to plan very carefully because it's not a small device, it's a couple of millimeters in size, about 8 or 9 millimeters in deep, so it's a big tin can. This is the development from the middle ear implant, which is only a couple of millimeters in size. So if you've got a healthy mastoid and you've got space, you can put it in there. You can't put them into mastoids that have had previous surgery, so it's a cortical mastoid, or you put them into the retrosigmoid placement. So again, this is a toy for adolescents and adults, so you do need a bit of bone thickness. I think the youngest they've done is of a 5-year-old, and there's been 9-year-olds, but I think in our armamentarium we're looking at teenagers and above. You need at least 4 millimeters of bone thickness if you're doing the retrosigmoid. That allows you to put perhaps 2 or 3 millimeters of gentle dural compression or depression, and there are called lifts, little plastic shoes that you can put it out, so that with the screws there's a little bit of protrusion, but again the profile is about the same as a cochlear implant. Some of the principles of surgery, sadly we call mastoid surgery exposure, exposure, exposure. See what you're doing, don't dig a hole. But with a Bonebridge, you need to engineer a very tight hole pocket to put the implant in, and you've got to be careful of the wings, which is where the screws go in that fixes the Bonebridge in place, that you've got enough bone for the screws to get into. So again, using good detailed high resolution CT scans and software to put your implant in is very useful. So it's a bit more complex. You have to pluck up the courage and don't be frightened about depressing the sigmoid sinus or depressing the dura. So the pearls are semi-implantable, mentioned not to be used in previous mastoid surgery. Planning is everything. You just can't go in and say, oh, just put it in there, because you might not have enough depth. So it's slightly more complex surgery, slightly more expensive than Sophono, and you've got enhanced frequencies to 4 kilohertz, and currently it's MRI conditional to 1.5 Tesla. I'll say that all of these devices have metal parts. Most of them will have, or all of them have, magnets. So no matter what we say, you have to consent these patients that if you have a head scan or a scan on the other part of the body, you will have deficiencies, or you could demagnetize this the device. So care and planning and understanding the past medical history of these patients is very important, because your fallback, your gold standard, and a lot of implant surgery is your Baha. We've been doing that since the 1980s. The titanium plug, ear level, 45, 55 decibels, with a cordel gives you a lot of range and movement. But some patients do like, no disrespect to the Baha patients, like no skin hassle. So there is a happy medium somewhere. The Esteem. Well, I'll go on to the next slide and come back. That's me. I was in Greenborough with David Bowler. We went over many years ago when the Esteem was being launched on clinical trial, to go to the lab to find out how to do it. And it is interesting surgery. It is quite complex surgery, and from the website, it is for people who perhaps don't want a hearing aid and they want something slightly different. And it's totally implantable. So you have a battery that they say lasts from about 3 to 9 years, on average about 5 years. Battery technology, I think, is improving day by day, and it has its merits. The surgery is challenging. I don't know whether it's supposed to. Yeah. It's interesting. Use the membrane, the tympanic membrane. You have a piezoelectric sensor that attaches to the incus. That goes into your processor, battery pack, which is all implantable, and the power output comes down, and the piezoelectric unit is attached to the head of the stapes. So if we can look at sort of the power output that's been advertised. I know Doug did some, you were part of the FDA studies, so it is quite a powerful hearing, coming right down to the 80s, 90 decibels. That's about as much as I know about it. I think it's got FDA approval now, but it is expensive, certainly from a UK point of view, depending on what benefit it gives you. There's a lot of caveats. It's 18 years of older. You've got to have stable inner ears, moderate to severe sensorineural hearing loss. So this is a device where Sophono, your bone conduction devices, wouldn't really be entertained. You've got to have a healthy middle ear, tympanic membrane, and above all, the space in the mastoid to put these two piezo electric units into the mastoid. They ain't small. The converse is the limitations. If you have previous middle ear disease, inner ear disease such as Meniere's disease, the defined fluctuating hearing loss as 15 decibels variation within the main speech frequencies in a 12-month period, central auditory processing disorders, and any sensitivity to materials, or if you have blood disorders or anything like that, and they throw in pregnancy. So this is probably still the criteria for when they had their clinical trial. These are my pictures of hands-on when I did it. So you've got your simple sensor. This is a left ear. You're taking off from the body of the incus, so that is picking vibrations from the tympanic membrane, and then what you have to do, the sacrifice, is you clip off the long process of incus and you put a capitulum and a contact onto the stapes. So you're having to sacrifice a normal acicular chain, and what I couldn't find is then you embed all this in ionized cement. It has to be fixed in there. So if you have any middle ear infections, or if you get any of the cement onto the actuating arms, you've got a problem. And when we were doing the testing, we had then a laser Doppler in to make sure that the sound frequencies are getting through. And if it didn't work, you had to dig it all out. So you could have a sort of 4-hour operation and find it didn't work, and then you take it all down again and redo it. And I think there's some of the colleagues on the temporal bone course, these were experienced surgeons, a total about 9 hours of surgery. So my experience was this is not something to play at. If you're going to do it, you'd have to spend a lot of time to it. But the inferences of absorbing the sound using your normal acicular chain is something that you could, I'm sure, use in other implants. What was slightly worrying, I don't want to do the system down because I don't know enough about it, but this is all published material on their website, was taste disturbance, because you need a big posterior tympanotomy, taste disturbance 40% plus, facial paralysis, 7%, 1% still going on after a year, tinnitus, again, 1 in 5 having tinnitus, and then list of things, obviously implant failure, removal, abandoning the surgery because there wasn't enough space, the correlation of the CT scanning, they couldn't proceed with it. So patient selection is very important, and there is a potential for a good auditory gain, and I'm not too sure if anybody knows about the compatibility about the MRI scan, but you've no magnets as such, but you've got a lot of clockwork in there, the batteries and things, so there will be some artifacts. Now, the Codacs, the Cochlear system, I was shown this many years ago in Vienna, and it was all quite exciting. So a lot of research has been developing around this over a long period of time, and I know my colleague Professor Briggs in Australia has done a few patients in clinical trials. I'm not too sure there's been any done in the USA. No, not yet. So I call this a powered stapes processor, and how it fits is potentially. I think we all appreciate that you've got in your country we have clinical criteria is about 90 decibels, whereas a lot of the bone conduction or hearing aids, there's this grey area between acoustic and middle ear implants as we know it, and then the cochlear implants. And it probably might fit that the DACS will take us from the bone conduction systems through until the cochlear implants, so that we have a process of uniformity of helping patients with their hearing. So that's a summary of what Cochlear Corporation can offer in hearing. Implant range severe to the mixed. That's indications for bone conduction thresholds, and this is obviously indications combined if you have a mixed loss, adding the air conduction. So you're getting into well into your hundreds of decibels. So candidates are going to be again central neural, poorly served by hearing aids, so that those are the patients where you're really cranking up the power and you're getting feedback, occlusion effects, and the whole principle is that they do give you very good gain, because you're driving the inner ear fluids like a stapes, so it's called a powered stapes. So bypassing the resonance of the outer ear, so you're not really getting any distortion. So you're going right from what would be an external microphone directly to the cochlear fluids, and you're not occluding or damping down the middle ear structures as such. So that you can see the principle of the actuator is sat within the mastoid, the arm comes through, and attached to the arm is your stapes, your prosthesis. So it's very delicate surgery to get the arm fixed to the bone and then manipulated into the stapes. So again, contraindications. Well, the indications will be advanced otosclerosis, not active chronic otitis media, and patients who can't use good quality acoustic hearing aids. So these were some of the surgical slides that have been sent to me. So again, the approaches are all very much like a cochlear implant. Wide exposure of the posterior tympanum. You can see the actuator arm getting through the posterior tympanotomy and then down into the stapes footplate. So the incus is removed, so the incus buttress is removed. So you can soon see how important access is to you. And you can see some outcome measures there of improvement. Here we've got 80, 90 decibels coming right up into very useful auditory levels. I think won't get too much. So again, a very powerful system planning. I don't know what the costs are, but they would certainly be not cheap, probably on par with a cochlear implant. And both this and the Esteem are using the technology of piezoelectrics, which are very powerful and not power hungry, but their longevity in the human body has been in the past an issue. I think that technology is improving. And again, I have no data regarding MRI compatibility, but currently there will be a magnet in the receiver package if you have an external processor.